This week's case of the week, we're going to take a look at an occlusal splint case, but I just wanted to bring up a couple general principles. Most of the dentists who are sending us splints are taking alginate impressions in their office, pouring these up, and then sending the models to us separately. So we end up getting models in the mail like this, and they're taken from alginate. And if they're taken properly, where you smear alginate on the occlusal surface with your fingers in the patient's mouth before you take it, you can definitely get a pretty good result with alginate. Pour it up, obviously, as quickly as possible, and then leave the model actually in the alginate impression and send that to us. You'd be surprised how many thin models we get, and as a result, we receive more broken models than we care to get, and then you care to get because you have to have the patient back and take another impression. So when you pour your alginates, leave them in the impression tray and actually send it out to us like that. It acts as a protector for the model, and we'll separate the model when it gets to us here in the laboratory. That's probably accounts for, probably 60 or 70% of the cases we get. And then the rest are impressions that are sent in from the dentist. If you're going to send it to us, please take it in polyvinyl or an alginate substitute material. To wrap it in a wet paper towel and send it in a baggie is just not going to get it done. And there are a lot of fit-related issues that we see related to distorted impressions. It really is the best way. If you want to take polyvinyl, and no need to pour it in your office, just send it to us. If you're going to take alginate to save money, take it, pour it immediately, and then just leave it in the model and send it out to us. Most of the dentists that we get send us a bite, where what they'll actually do is take bite registration material and they'll squirt it along the patient's lower arch, and then they just have the patient close completely together in maximum intercuspation. So we end up with a really thin strip of bite registration because the patient's biting all the way together. This really doesn't do anything for us, and we really don't need it. In fact, if you just want us to determine the thickness of the occlusal splint for you, just take a very nice upper and lower alginate impression and pour it yourself, or take polyvinyls and send it, and we will hand articulate the models. You don't even need to take that bite registration. But if in fact you want to determine the position the patient's going to be in, the thickness of the occlusal splint itself, you can certainly do that. There's a couple ways to do that. We have a video on our website showing how to do it with 2 cotton rolls, where the patient bites down into 2 cotton rolls, and then we do bite registration material here in the anterior, and then one on the posterior and one on the posterior over here. So we have a tripod, 3 little bites while the patient relaxes onto those 2 cotton rolls. I've seen doctors use golf tees. We literally will see golf tees that come in. They're kind of stuck to the bite registration, or even something like the handle of this scalpel could work, where the patient just bites and then something stops them from biting all the way together, so that you have a couple millimeters of space in between their posterior teeth. So there's different gauges and things that you can use to stop them when they bite together. And when we make a splint like that, we use these articulators. This is a Galletti Articulator. I don't know if you're familiar. You probably haven't seen one of these. It looks like something from maybe the turn of the century, and actually is designed a long time ago. But one of the nice things about it is it's a stone-free mounting, so the models just screw right into that articulator. That's one thing we like about it. Not only does it end up being cleaner, but you don't have the distortion from the mounting stone that typically holds these casts to the articulator itself, which can throw the bite off. So we feel it's very accurate, and then we can open, with this screw right here, we can actually open these 2 models apart from each other in a straight vertical direction to create thickness for a splint. So if you have a splint that you send to us and you want it at a certain diameter, and you used a couple cotton rolls to take the bite like this doctor did, we can make a splint for you to that exact dimension and replicate that on the Galletti Articulator. And so that's another reason that we like to use these articulators if you have something of a known thickness that you want. Now, most of the splints that we make are in fact this hard soft material, our comfort splint, as I wiggle this off, and you can always tell it's one of those by when you take your fingernail on the inside and you squeeze it into it, you can feel that soft layer. And one of the nice things about these hard soft splints is that if the patient doesn't wear it because they're not grinding their teeth for say 4 to 6 weeks, or maybe even 2 or 3 months, when they go to put this back in again, a lot of times if the teeth have shifted around, which teeth have a tendency to do, it can be very tight in certain areas, and with this soft layer on the inside, now all of a sudden it'll accommodate a little bit of that tooth movement, as long as it hasn't been more than a couple tenths. of a millimeter. Beyond that, it's a little more difficult to do. So this is our most popular splint. It's a very easy one to work with. It's comfortable because it's hard on the outside with the soft layer on the inside, but there's times where we don't quite have enough retention on the teeth. There's not enough undercut, and so we'll often call you and tell you that we want to switch you to something called an Astron splint, as you see here. And one of the differences with the Astron splint is you can see the little ball clasps that we have. So this material allows us to use some ball clasps to get some additional retention in addition to what we already have. And there's some other neat things. This is the Thermo active appliance as well, and in just a minute I'll show you how we can use this. So the Astron is also very good. It's hard, it's fully hard, there's no soft layer on the inside, but it's thermally active, so when we heat this up, we can actually, as you'll see, there's a lot of movement to it, and we can pop it into the patient's mouth while it's soft, and it'll reconform itself to the patient's teeth, and they can bite back into it, and as it cools in their mouth, it readapts itself to the teeth. So that's one of the neat things about this. One of the newer things we have, this is like the hard soft splint that you saw before, except this one's blue. This obviously isn't for daytime wear. This is for patients who are wearing it at night, but clear splints sometimes are a little difficult to find, and so this blue material is not an obnoxious blue, but it makes it easy to be able to find it when it's sitting on your bedside table, to see it if it happens to be in a glass of water, wherever the patient might put it, and it doesn't see the same kind of discoloration issues or the yellowing the way that the clear splints do. So this blue one's been one that's become more popular. This is a regular hard soft splint, and really the only difference is the color of the material itself. So let's go ahead and take a look at what happens if we heat some water up to 150 degrees, and then we're going to place this Astron splint in there for about 2 minutes. So I've heated this up to, in the microwave, to about 150 degrees. So I'll drop the Astron splint in there, and we're just going to leave it there for about 2 minutes. So we can just pretend that we've got a patient who is in for the initial delivery of this splint, and maybe it seems like it's rocking just a little bit or not kind of snapping in like it should. Or this could also be a patient who, as I mentioned before, hasn't worn it for 6 to 8 weeks, and it doesn't seem like it wants to go down all the way. In fact, if you trust the patient enough, they could probably do this themselves at home. If you trusted them to heat the water up to 150 degrees without burning themselves, it's about 2.5 minutes in an average microwave. Or if you trusted them not to put something that was too hot in their mouth. Probably better done by your dental assistant in the office, though, where the temperature of the water can be controlled, and then someone else can be there to put the splint in the mouth, make sure it seats, and then have them close into it. And once they've closed into it and you've let it cool in their mouth for a minute or two, I'll oftentimes take an air water syringe and use air and water to actually cool the splint while it sits on their teeth. So it's been 2 minutes, so let me go ahead and fish the Astron splint out of the water, and you'll notice what I can do with this now. You'll see, you can twist it like a pretzel, basically, and it goes back and forth and back and forth. And so we seat this now on our mythical patient on their upper teeth, and then we have them bite together, and they can hold it together tightly for about 2 minutes here. And when it's in the patient's mouth, any little distortions or tooth movement will now be accommodated by the Astron splint. It's not like they can take their wife's splint and you can heat it up and put it in the husband's mouth. But if it's the person's splint and there's been a little physiological tooth movement, you can have them bite together. And again, once it's been in for a minute or two, then you would have the patient open and then hit it with an air water syringe with some cool water to finish the cooling procedure on the splint itself, and then be able to take it out and then re-verify that it fits the patient. So again, that's the Astron splint. It's the one that we use when we don't have enough undercut on the teeth, and so we can put some ball clasps in there that'll help with it. And also one of the neat things about it is that it's thermally active. And so if we have a issue when we go to seat it originally or down the road, we can heat it up, put it back into the patient's mouth, seat it, have them bite together, and reestablish that fit.